Imagine a condition that can mimic a spectrum of diseases: itchy rashes, painful oral lesions, discolored patches, or even nail loss. Now picture the frustration of a patient dealing with these mysterious symptoms, often without a clear answer. This is the world of lichen planus, a condition that challenges both diagnosis and management. Today, we'll unravel the complexity of lichen planus, exploring its pathophysiology, clinical features, and the strategies to manage it effectively. Lichen planus is a cell-mediated immune response of unknown origin. It's not just a skin condition, it can affect the mucous membranes, nails, scalp, and genitalia, making it a true systemic challenge. Why does understanding this matter? To relieve symptoms like pruritus and pain, to prevent complications, such as scarring, pigmentation issues, or malignant transformation, and most importantly, to improve quality of life for patients. At its core, lichen planus involves an immune response gone awry. It's linked to altered immunity, seen in conditions like ulcerative colitis and alopecia areata. Rarely, there's a genetic twist, as in familial bullous lichen planus. Triggers can range from medications, diuretics, antimalarials, metal dental fillings, stress, to hepatitis C virus infection. Think of it as a condition that doesn't just show up, it brings a host of factors to the table. Lesions typically develop on flexural surfaces, often with a sudden eruption over 1 to 2 weeks, maximal spread, usually seen between 2 to 16 weeks. Pruritus can range from mild to severe. Oral lesions may be asymptomatic, or cause significant discomfort, while most cutaneous cases resolve within 6 to 18 months. Chronic forms like oral or hypertrophic lichen planus can linger for years. Lichen planus commonly involves mucous membranes, genitalia, nails and scalp, but its clinical variations are where it gets truly fascinating: hypertrophic, atrophic, erosive/ulcerative, follicular. Less common forms include vesicular/bullous, pigmentosus, and even pemphigoids-like presentations. It's a condition that wears many disguises, keeping clinicians on their toes. Diagnosing lichen planus often requires a multi-step approach. Direct immunofluorescence reveals IgM and complement deposits along with apoptotic keratinocytes. Histopathology shows a hyperkeratotic epidermis, civat bodies, and a band-like infiltrate of lymphocytes. These tools help differentiate it from its mimics. The pathophysiology ties back to a cell-mediated immune response, but triggers are diverse. Hepatitis C infection is a key association. Stress and genetic predispositions, HLA, B7, DR1, DR10, also play a role. Epidemiologically, it affects about 1% of new healthcare patients, often between ages 30 to 60, with no racial or geographical predisposition. While prognosis is generally good, complications can include malignant transformation, particularly in oral or vulvar lesions, permanent alopecia in lichen planopilaris, post-inflammatory hyperpigmentation, a visible reminder of the disease's impact. Up to 16% of patients also have coexisting hepatitis C infection, adding to the complexity. The primary goals are clear: control inflammation, manage symptoms, prevent recurrence. Treatment depends on the form and severity of the condition: topical steroids for localized disease, clobetasol, betamethasone, halobetasol; systemic steroids for widespread lesions, like prednisone tapering over 6 to 8 weeks, oral medications like acitretin, methotrexate, or hydroxychloroquine for stubborn cases. For oral lichen planus, topical steroids or calcineurin inhibitors like tacrolimus are effective. For widespread disease, phototherapy using UVB or PUVA offers significant relief. Educating patients is critical. Emphasize, the disease is often self-limiting, but recurrence is possible. Early diagnosis and treatment improve outcomes. Side effects of medications should be monitored closely. Lichen planus may present as a mystery, but with a strategic approach to diagnosis and treatment, we can transform the narrative from frustration to hope. Together, let's improve outcomes and empower patients to reclaim their quality of life. Thank you. Any questions?